So coming up to the subject of neoplasm, we can see that ovarian tumors are very, very deadly. If you summate the mortality of them vis-a-vis the other gynecologic neoplasms being uterine or cervical, it more than summates those other two gynecologic neoplasms. So although, fortunately, it's not all that common, halfway between cervical and uterine cancer, unfortunately, these are very malignant tumors. And if you look how we've done with imaging and talking about ultrasound over the years in terms of lessening the mortality, that we have not done. If anything, mortality is higher than ever. So it is a really terrible condition to have, and something that fortunately is not too common, but we should recognize it. Now, ovarian neoplasms come in 4 different types, as we can see here, from the least common sex cord stromal tumors to the epithelial tumors. Let's start with sex cord stromal tumors. As the name implies, these arise from the stroma of the ovary, or the scaffolding, in which, if you will, which contain the germ cells and the epithelial tissue that form other kinds of neoplasms. So this comes from the stroma of the ovary. They come in 3 different types. The most common is the granulosa cell tumor, and these are all solid. 2 of these tumors are associated with hormone production, the granulosa tumor with estrogen, and the sertolic lydy with androgen production. So if you have a postmenopausal patient and she suddenly has symptoms, maybe she's getting her period again, that sound like she's got feminizing hormone on board, she probably has a granulosa cell tumor, and in contrast, if masculizing symptoms appear, you're going to think about a sertolic lytic tumor. Fibromathecoma is the 3rd tumor that develops from the stromal elements of the ovary, and it, as every medical student knows, is associated with Meg syndrome, which I've seen all of 2 cases, I think, in my 40-year career. And these are patients who have effusions with a benign tumor, ascites, pleural effusions, pericardial effusions, and these are benign. The other 2 tumors, fortunately, have low malignant potential, grade 1 tumors, so these are not wildly anaplastic the way the epithelial tumors are. What about these cases? 2 different patients with rounded, relatively small mass, larger mass in the ovary, with Doppler flow that is consistent with a neoplasm. Well, if you have these appearances in a woman, these don't look like normal ovaries. They are rounder than a normal ovary, and we do not see the follicles. These are patients who have ultimately proven stromal tumors in association with feminizing and masculinizing symptoms. So knowing if it's masculine or feminine in terms of their symptomatology and excess hormone can help you decide which it is. But overall, I let the pathologist give me the results of what these solid tumors are. A 3rd solid tumor can be associated with acoustic shadowing due to attenuation of sound and reflection of sound, and similar to leiomyoma of the ovary, these are fibromathecoma, and they're related like fibroma to the fibroid tumors, fibrous elements, and these can absorb sound, as we see in these examples. So if you ever see a mass that has some shadowing, that this is not what a dermoid looks like, it's coming from the solid component of the tumor, think of ovarian fibromathecoma. And here we show you in contrast a normal ovary with its normal shape. Ovarian masses tend to be round as opposed to ovarian normal ovaries, which tend to be elliptical. What about metastatic tumors? About 10% of ovarian tumors arise from metastatic disease. About half, or more than half, come from the GI tract or the breast, and then the rest we see from other tumors. And basically, these tend to be solid or cystic with a large solid component within them. And this is Dr. Netter's depiction of a patient who has a solid tumor with some small cystic elements. Anytime you see bilaterally enlarged solid ovaries, think of metastatic disease first, though. Gastric cancer in this case, with so-called Krukenberg tumor, another patient with lymphoma. What about germ cell tumors? Well, they come in a variety of types. We're going to focus on the mature dermoid, if you will, which is certainly the most common if you're dealing with an adult population. So what do these look like? Well, 18% of them up to that number are bilateral, and as the name teratoma implies, they're associated with the germ cells of a variety of types. But we tend to focus our attention on the ectodermal elements, or the hair or sebum within dermoids. Now, when I asked residents to tell me what's causing this echogenic area with the gradual acoustic shadowing, I often get the wrong answer. So let's think about this. It's actually the hair that is hyperechogenic with the gradual acoustic shadowing, as the hairball, if you will, absorbs and reflects sound, giving you a relative gradual acoustic shadowing. The sebum is actually the liquid at body temperature. It's like taking butter or fat, lard, Crisco, and heating it up to become liquefied at body temperature. So this is the liquid due to the sebum with varying echogenicity. Sometimes it's very echogenic, sometimes it's quite echopoor. And here we have case number 6 in our grouping of a classic dermoid. We're seeing a focal hairball, if you will, comparing it to the CT, making you realize that the sebaceous material is typically liquid at body temperature and has varying degrees of echogenicity within them. So you should be able to recognize these classic dermoids, but there are variations. Here we have a patient who has what looks like mural nodules in a cyst. I'm not going to let those slide by me. That will come out fairly soon, although this one does have acoustic shadowing. If you were to do a CT in this case, each of these are dermoids within the wall of a simple cyst. These are too small to resolve even today by CT. So that is called a dermoid plug. Here we see calcification in a dermoid, very bright echo with acoustic shadowing, and that is another example of why we miss dermoids. Here we have a third case, which we have a large, what looks like a solid component, but it's really sebum filled with echogenic fluid, and here's the hairball floating in the fluid. And finally, the fourth variation that we see is here's the hairball, and these echoes are linear. If I showed you a clip, they would be undulating and sparkling. This has been published as the spaghetti sign, but I would like to suggest a better name for it might be a bad hair day with hair flying into the liquid of the dermoid.